My name is Kate Gates, Vice President of Advocacy and Programs with the Pulmonary Fibrosis Foundation. Thank you everyone so much for joining us today. We also have Scott Stasic here with us, who is our President and Chief Executive Officer. You can use your control panel at the bottom to ask questions. I see someone has already put stuff in the Q&A. We'll have questions at the back. I'm sorry, we'll have questions at the end of this session. And you can ask any questions, also any technical questions. I can't say that we can help you with technical questions based on this experience, but we actually do know something about Zoom and can help you if you have any technical questions. I want to go ahead and turn it over to Scott so that we don't take any more time. As I said, he's the President and CEO of the foundation. Go ahead, Scott.
Great. Thank you, Kate. I want to welcome everyone today, and I want to let you know how happy we are to have you here at the 2024 PFF Education Symposium. As the nation's leading pulmonary fibrosis research, education, and advocacy organization, it's incredibly energizing for us to host this event. We look forward to discussing the latest in PF research and care with you throughout today. This morning, I'd like to share the PFF's mission and our major programs and services with all of you. But I'll start by telling you just a little bit about myself and my background, and why it's truly an honor to serve at this organization. I began my career as a social worker and have always been motivated by the opportunity to help others. When I joined the PFF in 2011 as Chief Financial Officer, I had no awareness of the disease, very similar to many people when they're diagnosed. In 2014, after I'd been working at the foundation for 3.5 years, my mother nonchalantly told me that she'd been put on supplemental oxygen. Upon further conversation, she disclosed that she'd been diagnosed with idiopathic pulmonary fibrosis. As you can imagine, this came as a complete shock to my family and to me. This personal experience not only furthered my purpose and resolve, but it also gave me an inside perspective as to what patients, caregivers, and family members experience with living with pulmonary fibrosis. My mother's memory fuels my devotion to this community. So having said that, the mission of the foundation is to accelerate the development of new treatments and ultimately a cure for pulmonary fibrosis. We are dedicated to advancing care and providing the best possible support and education resources for patients, their caregivers, and family members. In addition, the PFF partners with healthcare providers by offering clinical resources, community engagement, and research opportunities. The foundation was established in 2000. So if you're good with math, you'll realize that in 2025, we have a big year coming up with our 25-year celebration. In these 25 years, we've developed a range of impactful initiatives aimed at raising awareness and providing support for the community. Our programs and services focus on 3 main areas: research, education and support, and advocacy. I'll start with research. Since our founding, the PFF has invested $5.5 million in research grants via the PFF Scholars Program, with a return of $277 million. In essence, that $5.5 million that we awarded, those same researchers went out and were able to secure subsequent funding to the tune of $277 million. The PFF registry is our largest investment in research and our most powerful research tool. It consists of 2 separate databases. The first is the patient registry, which opened for enrollment in 2016 and then closed in 2022. This is a clinical database with information from 2,000 patients. Information from the registry has been used for more than 80 studies, which represents more than $50 million of research funding that otherwise would have been needed to conduct that same research. The community registry launched in 2022 and is recruiting patients, caregivers, biological family members, and lung transplant recipients affected by pulmonary fibrosis and interstitial lung disease. Unlike the patient registry, where it was constricted to patients only at certain medical centers, anyone can participate in this. It's a self-reported registry that collects information entirely online. All you need is internet access to join. Current enrollment in the registry is 2,341 people. If you're not in the community registry, please visit pffregistry.org to enroll. It's very easy. I'm in it. There's no limit on enrollment, and the registry becomes more valuable to researchers as it grows by participants and over time. And if you're already in the community registry, this is a friendly reminder to please keep up to date with your 6-month surveys. We make this data available to medical researchers who are working to improve the lives of everyone impacted by PF. Also, in order to facilitate PF research, the PFF offers a robust clinical trials education center on our website. Our clinical trial finder tool enables patients to quickly and easily navigate relevant and feasible clinical trials. This tool allows viewers to search by study, phase, disease intervention type, and more. This is really important as the drug development pipeline is the strongest it's ever been in this disease space. Also, our monthly PFF clinical trials newsletter features important updates on new research opportunities. I hope you will all join today's clinical trial innovation series. This is the therapeutic pipeline for PF and ILD, which is, as I said, more promising than ever before. So now let's talk a little bit about education and support, as they really do go hand in hand. The PFF Care Center Network, or CCN, touches on all 3 of our priority areas. The Care Center Network is a collaboration with communities across the country that enables us to, first, offer access to multidisciplinary expert care and cutting-edge research. Also, achieve earlier diagnoses for patients with PF and enhance understanding and awareness of PF. The Care Center Network includes 81 sites and 7 clinical associates in 39 states, as you can see on the map. We want to bring the resources of the PFF to as many of the more than 250,000 Americans living with PF and ILD as we possibly can. Through the Care Center Network, we also establish partnerships with community hospitals, pulmonologists, and nurses. A diagnosis of PF can be overwhelming and isolating, and one of our primary functions at the PFF is to provide support. We connect individuals through 137 support groups in 37 states and 13 international support groups. We've also expanded our Zoom support groups to offer groups focused on caregivers and the lung transplant community. Support groups are extremely helpful for sharing experiences, practical information, and resources. Often friendships develop from support group connections, and there's a strong sense of camaraderie. Some members of our community participate in multiple support groups. The PFF also assists the community worldwide through our help center. We respond to phone and email inquiries from people who have a range of questions and are interested in receiving free digital information about pulmonary fibrosis. Whether you're a newly diagnosed patient, a caregiver, interested in finding a support group, or a physician looking for healthcare professional materials, the PFF Help Center is available to you. Last year, we connected with more than 5,000 members of our community through the Help Center. Some of the inquiries we received through the Help Center are routed to our medical team. We're very fortunate to have them, and you're going to meet some of them today in an upcoming session. Dr. Amy Hajari-Case, Dr. Sonia Danoff, Dr. Kevin Flaherty, and Dr. Joyce Lee are all highly respected pulmonologists who provide valuable input and oversight for our programs, including our educational materials. An example is our PF Basics Info for Newly Diagnosed Patients program, which we are launching this week. Next slide. Thank you. We understand how frightening and confusing a diagnosis of PF can be, and we want to make sure that no one faces this journey alone. And this bears repeating, you are not alone. Our program for newly diagnosed patients features a series of modules that can be explored at your own pace. They include treatment options, your medical care, peer support and PFF resources, living with PF, and finally, research and clinical trials. Each module contains links to more in-depth resources with the PFF website, so additional content is easily accessible. You'll find the newly diagnosed patient program prominently featured on our website. This just launched yesterday, so we're very excited about it. Knowledge is power, and the PFF's education materials cover everything from emergency preparedness to supplemental oxygen basics. Many of our fact sheets and guides are available in multiple languages to ensure that information is available to everyone who needs it. We also provide educational videos and webinars that are available on the PFF YouTube channel. You can find sessions from the PFF Summit, patient stories, and much more. I'd also like to talk about our advocacy efforts for a moment, especially the pending Supplemental Oxygen Access Reform Act, also known as the SOAR Act. It currently has bipartisan support in Congress. The SOAR Act is an example of how we work with public officials on issues that are important to our community. This includes meeting with elected officials, in particular those working at federal agencies such as the Centers for Medicare and Medicaid Services. In addition to oxygen reform legislation, we advocate for PF research funding through the National Institutes of Health, the National Heart, Lung, and Blood Institute, and congressionally directed medical research programs. These are some of the largest buckets of funding for research in the United States, so this advocacy for the continued funding of these programs is critical. We need your help. You can become a PFF advocate and receive updates and alerts by signing up on our website. Advocacy is one of a number of meaningful ways to engage with the PFF. We invite you to try as many as you would like. Connecting with the PFF on social media is a great first step. Sharing information about the disease helps us raise awareness. You'll find us on Instagram, LinkedIn, and Facebook. If you enjoy events and fundraising, you can join Team PFF to create your own event and/or participate in the PFF Walk. We also hold an annual gala, Broadway Belts for PFF, led by PFF board member and Tony Award-winning actress and comedian Julie Halston. In September, we invite everyone to join together for Pulmonary Fibrosis Awareness Month. People impacted by PF all over the world send us their stories, share information about PF on social media, and help us organize iconic monuments to light blue, as you can see in the photos here. This year, all 50 states went blue for PF for the first time. So thank you to everyone who talked to locally to get their buildings or monuments lit up blue. Because of you, PF Awareness Month gets bigger every year. We're building great momentum, and we appreciate your energy and participation. I want to thank you all for your support and involvement with the PFF. We could not do the work we do without your help, input, and participation. Remember, we're a patient advocacy organization, and patients, caregivers, family members, etc. It's a community that thrives with a strong, healthy organization. Remember that the PFF is here for you. I've said it earlier, but I'll say it again. You are not alone. We're on a mission together with you to find a cure for PF. Every step we take brings us closer to a cure. I want to thank you again for your time this morning, and we look forward to spending the day with you.
Thanks, Scott. I think we have Dr. Case joining and our other panelists as well. Really appreciate your presentation. And a reminder to put any questions in the Q&A section.
Thanks, Kate and Scott. Good morning, everyone. I am Dr. Amy Hajari Case, and I am the Chief Medical Officer at the Pulmonary Fibrosis Foundation. I am coming to you live from Atlanta, Georgia this morning, where I also work at Piedmont Healthcare. Excuse me, I am the Care Center Director, the Director of the Advanced Lung Disease Program and Pulmonary Critical Care Research here also. And I am so glad that you decided to join us today for the PFF's Educational Symposium. As we kick off with our first session today, I wanted to acknowledge that we have many people who are new to the PFF community in our audience. And I also want to recognize the importance of providing some basic information on pulmonary fibrosis before we dive deeper later in the day. But I also know that many of you out there have joined our educational events in the past and are familiar with the basics. So to keep things a little fresh, go with us here. I invited some of my colleagues to join me in a little game that I would like to call, wait, please tell me, the PFF Fact Quiz. Hopefully I won't get in any trouble with a National Public Radio. Joining me today, I have some great panelists and colleagues. First off, I have Dr. Sonia Danoff. She is a professor in the Division of Pulmonary and Critical Care Medicine, director of the Interstitial Lung Disease and Pulmonary Fibrosis Program, and associate director of the Myositis Center at Johns Hopkins Medical Center. She specializes in diseases that cause fibrosis in the lung, particularly those associated with autoimmune disease, including myositis. And she actively participates in national and international collaborative groups in the study of ILD. She is also one of our senior medical advisors at the Pulmonary Fibrosis Foundation over the Care Center Network. Welcome, Sonia. Thank you for being here today. Next up, I have Dr. Joyce Lee. She is a professor of pulmonary sciences and critical care medicine and director of the Interstitial Lung Disease Program at the University of Colorado School of Medicine. She established the university's ILD program, which is now part of the PFF's Care Center Network. Dr. Lee has developed clinical and translational research programs with both NIH and non-NIH funded investigator-initiated studies and clinical trials. Dr. Lee is our Senior Medical Advisor for Research and Healthcare Quality at the Pulmonary Fibrosis Foundation. Welcome, Dr. Lee. Thank you for being here. And finally, last but not least, certainly Dr. Ross Summer. He is a board-certified pulmonary critical care physician and an NIH-funded investigator. He started the ILD program in 2012 at Thomas Jefferson University in Philadelphia. He is a professor of medicine, the section chief of pulmonary and critical care at Thomas Jefferson University Hospital, and also the Care Center Network site director at Thomas Jefferson University. He maintains an active laboratory and oversees clinical trials related to pulmonary fibrosis. Welcome, Ross. Thank you for being here. If you could step on the stage so we can see you. Maybe I can. There you are. Excellent. Thank you all for being here today. We are going to get started. Oops, here we go. All right, so we have round one, which I have to find in my notes. If you guys want to talk amongst yourselves, I can give you a topic. All right, here we are. For our first round today, we are going to test your knowledge of the Pulmonary Fibrosis Foundation's educational resources. So as we go around, I'm going to read direct quotes from 3 different educational items that we have available for folks to use and ask you if you can identify the source. You will win a point for each of those that you can correctly identify. Are you guys ready? Great. Everybody ready? Play? Yay. Okay. All right, here we go. Joyce, I'm going to start with you. Here is your first quote. There are more than 200 types of interstitial lung disease, or ILD, which are characterized by varied amounts of inflammation, scarring, or both that damage the ability of the lung to absorb oxygen from the air. Joyce, can you identify the source of this quote?
I think I can. And in fact, I have the pulmonary fibrosis. Oh, I don't know if you can see that information. I think it's because it's blurred out the background. Hold on, maybe like this.
There it is.
On page 2 here, you can see that exact quote.
Amazing. And so for those out there who aren't aware, we do have a number of printable and printed materials. The Pulmonary Fibrosis Information Guide is one among them. You can find those on our website. Joyce, what can you tell us about interstitial lung disease here?
So as many of you know, interstitial lung disease and the term pulmonary fibrosis are often used interchangeably, but both of them are umbrella category terms that encompass over 200 conditions as stated in our information guide. Some of these are really limited to the lungs. Others might be manifestations of a broader systemic autoimmune condition, and others can be related to exposures that you experience over time. So pulmonary fibrosis basically just means lung scarring, and we worry about these conditions because they can be progressive over time. And when the lungs scar, they become stiff and they lead to symptoms of shortness of breath and also low oxygen levels in certain patients.
Thank you so much, Joyce, for that great overview. Next up, here we go. Great job. How about this quote for Ross? You're up next. The most common symptom of pulmonary let me get it right, of pulmonary fibrosis are dry, persistent cough and shortness of breath. Symptoms may be mild or even absent early in the disease process. Can you?
Wow, this is a tough one. I'm going to go with the PFF website.
Excellent. Really well done. That is a really deep cut from the website there, Ross, but really spectacular knowledge. So tell us a little bit, if you can, about symptoms of pulmonary fibrosis.
Yeah, sure. Thank you. So, I think this quote actually underscores one of the major challenges with pulmonary fibrosis, so that the symptoms are often non-specific. The term symptoms refers to, signs or experiences that patients have that point to a specific disease. So, for example, if your ankle hurts after a fall, that kind of is a symptom that may be related to a fracture or an injury. Or if your belly hurts on the lower part on the right side, that may be a symptom of appendicitis. But in pulmonary fibrosis, the symptoms are very nonspecific, and shortness of breath and cough can happen in many other conditions. And I think this is what leads to kind of delays in diagnosis, and often people seeing multiple doctors before getting to a pulmonologist. I think we need to do a better job at raising awareness of pulmonary fibrosis and the nonspecific nature of these symptoms. And I am going to propose today coming up with a catchy tune to say something about the symptoms. For example, cough playing a leading role in your life, think pulmonary fibrosis, but I'm open for other ideas.
I think that's really brilliant. I know some little boys who might collaborate with you on that jingle if you're interested, because I do think short and sweet will help people remember.
I like it.
Yeah. So this is another just demonstration of some of the impacts of pulmonary fibrosis on people's quality of life on the basis of symptoms. Ross, you mentioned cough and shortness of breath, another word for that being dyspnea. So that's something you might see in medical literature as a term. But people also experience other impacts on their lives, fatigue, anxiety and depression, some deconditioning that goes along with not being able to do the things that they used to do, and then becoming further unable to do daily activities or exercise. And then certainly we think about other medical conditions called comorbidities that can be associated with pulmonary fibrosis, and then the impact of medications that can sometimes have side effects associated with them, that all go into that that blender that creates impacts on quality of life. So great job, Ross. I commend your knowledge of the pulmonaryfibrosis.org. Great. Sonia, I have one for you. I hope this one doesn't stump you. I have here the reported median survival of 3 to 5 years in idiopathic pulmonary fibrosis was established over 2 decades ago, and the care of patients with IPF and other interstitial lung diseases has changed considerably since then. Sonia, what do you think?
Gosh, that's a tough one, Amy. It sounds familiar, but I don't know exactly where it comes from. Could you give me another clue, please?
I have a hint for you. This also comes from that same resource. No statistic can tell you how long you will live with pulmonary fibrosis. I know you're going to get it now.
I think I can figure it out now. It seems to me that I remember a video that talks a little bit about that. Maybe you could share that with us.
Excellent. Really great job. Yeah. So we have our video queued up here. Hopefully it will work. Let's see. We can get it to go. If not, I will make a description of it. Doesn't look like it's going to play, you guys. I hate that. Pointer options. All right. Well, we're stuck. This is, as you correctly identified, a wonderful short video which addresses a commonly quoted statistic that people find on the internet frequently when they first start investigating pulmonary fibrosis or interstitial lung disease. And Sonia was the star of this video. She gave all of the information very succinctly. This video can be found on our YouTube channel along with a number of other short videos on quick topics that you can look through. And then also some of our longer materials, our webinars are recorded and will live there, as well as past summit sessions are on our YouTube channel. So any of the topics that we've covered in video format in the past live there. They can be linked to from the pulmonaryfibrosis.org website. Sonia, I can't show our video here. I hate that. Could you tell us a little bit about what you were sharing in that video?
Absolutely, happy to do so. You know, I think that one of the problems that we have when we try to communicate with our patients is that we talk about the likelihood or the life expectancy, and we're really talking about a whole group of people. So it's as if we had 100 people in a room and we're saying on average, what is it that we would expect to happen? But that doesn't really actually impact the individual, because every individual lives a different life. And so I think that the really important pieces here are that, you know, we first need to know what the diagnosis is. A lot of the data we have is based on people who had a diagnosis of idiopathic pulmonary fibrosis. And not everybody who has PF or ILD has this diagnosis. And so the statistics on survival are very different. And again, you know, a statistic is based on a population. It's not an individual person. So for sure, when somebody maybe reads that and they think, oh my gosh, you know, I have 3 years to live, that's not really the case. That's really that on average in that room of 100 people, there are going to be some people who will live less than 3 years. There'll be some people that live more than 3 years, but all of that is going to depend on the diagnosis. And I think that the other thing that we have to understand is that a lot of the numbers that we have that were used for survival were in a very different time for our patients with pulmonary fibrosis. And now we diagnose people much earlier in disease. So the point in your disease course will affect your life expectancy and that can sometimes be determined by your lung function, which is why we ask people to have pulmonary function tests. We have new treatments that have improved outcomes. And so the response to treatment is also very important. And then sometimes there are other things that happen in our patients that may impact their life expectancy that have really not anything directly to do with their pulmonary fibrosis. So there really is a lot of variability in those numbers, and nobody should be defined by a specific number.
Well said. Thank you, Sonia. The link for this particular video has been sent to everybody that is in attendance today, and so you can open that up. Don't watch it right now because we're going to get to some other topics, but and bookmark that to go back to it, and then also explore other videos that we have available on our YouTube channel. So we're ready to go to round two. I think we're neck and neck. Everybody's tied with one correct answer. So we're doing great. Now we're actually, before I get started, we're going to invite our audience to get involved and help our panel answer some of our fact or fiction questions. So these would be true and false questions about some common myths and misconceptions about pulmonary fibrosis. So when I go to the question, it will pop up on your screen, and we'll give you a moment to go and answer that and submit that answer. We'll see how you guys do in the audience and see if you can help our panelists answer those questions. So hopefully you've had some coffee this morning and you're ready to go. All right. Joyce, I am back to you. True or false? No one knows what causes pulmonary fibrosis. And so we'll give everybody about a minute here to answer our question. Everybody's answers are rolling in here. Got neck and neck. I don't know if you guys can see on your screen, but doing great. Everybody's getting their answers in. All right. Give it about 5 more seconds. If you're still thinking, almost time. All right. I'm going to end that poll. We are about 51% true and 49% false. You guys can see those answers. So that's a really, I don't know how much that helps you there, Joy.
Amy, I think it's actually a pretty tricky question, right? Because I think the answer depends on your diagnosis. So if you can go to the next slide, certain causes are certainly certain types of pulmonary fibrosis. I think we can all agree we don't know the cause for, but there are numerous types of pulmonary fibrosis for which we do know the cause. So some of them are listed here. So we can have drug-induced pulmonary fibrosis. Radiation treatments to the chest for breast cancer or lymphoma can lead to pulmonary fibrosis. Certainly environmental causes of pulmonary fibrosis, which we term hypersensitivity pneumonitis. And probably one of our bigger ones, one that Sonia is very familiar with, is autoimmune-related interstitial lung disease. So we know that the lungs can be a manifestation of underlying autoimmune diseases like rheumatoid arthritis and scleroderma. And then finally, certain occupations can certainly lead to pulmonary fibrosis. So that was a little bit of a trick question for our audience, I think.
Yeah, that is true. I guess we can say that there are no wrong answers on this particular question. Great job, Joyce. Thank you so much. Ross, you are up next. Let's see if our audience can help you with this one. True or false, a lung biopsy is necessary to diagnose pulmonary fibrosis. So this is another tricky one, depends on your experience and where you might be thinking here. So let's give the audience maybe about 15 more seconds to get some answers in. You guys are doing great, panelists and audience. Everybody seems to be awake and in the game today. All right, let's share those results. Now, Ross, you've got some overwhelming votes for false here. A lung biopsy, they think, is not required to diagnose pulmonary fibrosis. Are you swayed by that?
I think I'm going to go with the audience. I think they are much smarter than me.
Tell us a little more about that, if you will.
Yeah, so actually, this is actually an important point. I'm glad that the responses leaned in this way. So this is one aspect of my job that has changed dramatically since the start of my career. And I think, standard of care in pulmonary fibrosis has evolved with our knowledge. And so one of the major areas in which we've had an evolution is towards lung biopsies, and that we don't do them in a lot of cases. They are necessary in some cases. So some people may have undergone lung biopsy, but, advances in our understanding of CAT scans. So the ability of a CAT scan to actually predict what we think we're going to see under the microscope has helped enormously. Also, the addition of serologies or blood tests, as is outlined in this, that has been a major advancement. And then now we're actually better with taking histories and physical exams and looking for subtle changes that may point to specific diseases. And so for all of these reasons, we now have a collective group where we have multiple discussions with rheumatologists and other providers and radiologists, and we come up with diagnosis trying to avoid lung biopsy because of the potential complications associated with it. So the answer to this is false.
Very good. All right, you got it. Sonia, it is your turn. Here we go. True or false? We'll let the audience help you on this one too. A multidisciplinary discussion is considered the gold standard for diagnosing interstitial lung disease. Audience, let's see what you think. You guys are getting really good at answering these questions, so you're going to be ready to go when I hit you with the multiple choice in a few minutes. We'll give everyone maybe about 5 more seconds. Get those answers in. All right. Let's see what we have. Now, Sonia, we've got an overwhelming majority feeling that this is true. What are your thoughts on that?
Well, I agree with Ross. I'm going with the majority on this one. And I am also just incredibly delighted that this is something that is recognized as being a part of the care of our patients with interstitial lung disease. If you don't mind going to the next slide. So multidisciplinary diagnosis was shown to be superior to people sitting in a room by themselves trying to figure out what it is that a patient has. And essentially, this is our opportunity to sit down with our colleagues and put our heads together to really understand all of the components of the information we have that Ross was discussing that contributes to a diagnosis. So there might be story from the pulmonary doctor about what the clinical situation was, what the history was, what kind of symptoms a person had, what kind of lab testing they had done. And then our expert radiologist would sit down with us and say, here's what I'm seeing on the CT scan, and this is what that makes me think of. And if by chance there is a biopsy, which as Ross said is not as common now, the pathologist might join us. We might even have other people. We might have a rheumatologist in the room with us if it's a patient where we think there might be an autoimmune disease. We all sit together and say, what do we think is the most likely diagnosis? And then we often will also go on and say, well, if that is the most likely diagnosis, what else needs to be done? Are there more tests that need to be done? What kind of therapies need to be done? So this multidisciplinary diagnosis, which I would call a multidisciplinary discussion, is really key to coming to an appropriate and accurate diagnosis and finding the best path forward.
Excellent. Well said. Thank you so much. All right. Well, our audience is 3 for 3, I think we can say. You guys are doing great. And next up, we are going to take a break from our panel and have time for a little section we're going to call Not My Job. If anybody listens on Saturday morning to that National Public Radio. I'm going to invite Scott back to the stage here. Scott Stasek, the president and CEO of the Pulmonary Fibrosis Foundation. Scott, welcome back.
Thank you. And just to clarify, you'll never hear me utter those words. Not my job.
Very good. Perfect. You are the CEO now. You have held multiple roles at the Pulmonary Fibrosis Foundation. You alluded to some of that earlier, and you came to the PFF in 2011. What other jobs have you had with the foundation?
Well, I started as chief financial officer and served in that role for about 4 years. And then I moved into the chief operating officer role and served that for about 9 years. And then just this summer, I moved into the president and CEO position. So it's given me a pretty rounded, holistic viewpoint of the organization.
Excellent. And I know that I in particular appreciate your long view of the foundation, and your memory of things from the past is really a great resource, I think, for all the folks at the foundation. And you also alluded to this, but I do understand the mission of the PFF is really close to your heart because of that personal connection to pulmonary fibrosis. Do you want to tell us just a little bit more about that, about your mom?
Sure. So this morning when we opened the meeting, I did share that my mother was diagnosed with idiopathic pulmonary fibrosis. Her story was not unlike many patients, though. When she was diagnosed in mid-2014, she was probably living with the disease for many years. Unfortunately for her, she'd had juvenile diabetes and she'd had numerous health issues related to that, even becoming non-ambulatory or in a wheelchair because she had lost bone mass in her feet. So a lot of the symptoms were somewhat overlooked or just not even recognized until in a very advanced stage. So that was really disheartening to have that diagnosis occur at such a late stage in the disease.
Yeah, I think you really hit that point for so many people is that that delay is stressful, it's confusing, and I think I know that you feel very strongly about efficient and accurate diagnosis for our patients in our community.
And I recognized that we were in a luxurious position of I was working at the foundation, and most people do not have access to the information that we did in my family. So having that lived experience makes me even more committed to making sure that others have the same opportunity for access.
Absolutely. Thank you for sharing about that personal experience. Our audience may not know this, but the PFF is actually heading into a big anniversary year in 2025. Can you give us a little hint about what's in store for our community next year?
Sure. For our quarter century mark, we have a number of things planned, but I'll touch on just a couple. So first, the PFF Summit, which we hold every other year, will be in Chicago in November of 2025, specifically November 13th through the 15th. This is the first time that it's back in Chicago since it launched in 2011. So we're really excited. And I know some people think November in Chicago might be a bad time of year to visit, but I'm telling you the seasons have shifted. So it doesn't get super cold in November. Of course, now that I've said that, I'm going to eat those words. We've also begun work to develop our next strategic plan, which is intended to be a 5-year plan. And we've just launched effort on that. So in 2025, we will be publicly launching this plan. Additionally, one of our fantastic fundraising events, Broadway Belts, which I mentioned earlier, which is hosted by Julie Halston of our board of directors, is celebrating its 15th year. That launched a month after I started at the foundation was its first event. So that was pretty fantastic. And we had Liza Minnelli show up and perform that first year. And then most importantly, though, we're going to take the opportunity throughout the entire year to celebrate and highlight all of our PFF community members and tell your stories and share them in a very thoughtful manner and spread awareness and allow you to have a voice in that.
Excellent. Well, thank you, Scott. I really appreciate you sharing all of that. But we have asked you here actually to answer some questions. We're going to play this game and we can call it Not My Job. Well, actually, it kind of is. And we're going to ask you questions about pulmonary fibrosis. So we'll give the audience this time also an opportunity to help you with any of those questions if you need a little assistance with those right answers. Are you ready, Scott?
I think I am.
All right, let's get going. All right, audience, here we go. You did a great job with our fact or fiction questions. Let's go with some multiple choice. Which of the following is a risk factor for pulmonary fibrosis? Is it A, cigarette smoking? Is it B, family history of pulmonary fibrosis? C, occupational exposures, including vapors, gases, dust, or fumes? Or D, all of the above? I think our audience are master test takers because if all of the above is one of the answers, you know what that means. All right, we'll give everybody about 3 more seconds here. Get those answers in. All right, let's see those answers. Here we go. Scott, are you going to cross the audience here? They seem united.
I dare not go against the grain with this one. And I do know the answer to this, that it is D, all of the above.
Excellent, excellent. Yeah, you're right. And so is the audience. Thank you for that. Yeah, so risk factors for interstitial lung disease and pulmonary fibrosis are many, actually. And you know, we mentioned some of the things we're exposed to in the course of life, including the smoking of cigarettes, environmental or occupational exposures. Joyce mentioned earlier medications and radiation that we can also be exposed to, although there are some intrinsic things that put us at risk for pulmonary fibrosis, including genetics. A number of people have familial pulmonary fibrosis or familial interstitial lung disease, and then autoimmune disease, which we've also talked about. And this is not an exhaustive list. I think we know a fair amount of things that increase risk, but none of these these are not necessarily associated with a definite progression to interstitial lung disease and pulmonary fibrosis. So, Scott, you got that one right. Good job. All right, here we go for our next question here. If people were listening earlier, might have a clue to the answer to this question. Which of the following is a way to get involved in pulmonary fibrosis research? Is it A, the Clinical Trial Education Center on pulmonaryfibrosis.org? Is it B, searching for trial opportunities on the PFF Clinical Trial Finder? Is it C, joining the PFF Community Registry? Or is it D, all of the above? Yeah, it took me a while to read those. Everybody's almost gotten their answers in. Let's give those about 3 more seconds and we will show the answer to our poll.
I'm hoping we have a pretty unanimous answer here. Otherwise, it means we have more work to do.
That's right. I think we might be preaching to the choir here. Let's see those answers. Yep. I think we've got a consensus on D, all of the above. Scott, what are your thoughts there?
Again, I'm going to have to join the majority here and agree.
Excellent. Good job. Yeah, great job, everybody. You are right. And I know you heard a little bit earlier about ways to get involved in research through the Pulmonary Fibrosis Foundation's Clinical Trials Education Center. This is a great spot on our website where you can learn about clinical trials. If this is something that you've not heard of before or don't have a good sense for or comfort level with, there's information about the design of clinical trials, the phases, what all of that means, and what it's like to participate. We have our clinical trial finder where you can actually register for a profile there, put your own information in if you like, and match to studies within a certain radius of you, and even reach out to those sites that are doing those studies to see if you are a good fit. We have telephone and email support for that service as well. And Scott mentioned earlier the Pulmonary Fibrosis Foundation's community registry, which is open for enrollment to anybody in the United States that is a patient living with ILD or pulmonary fibrosis, a caregiver of a person who has had or passed away from pulmonary fibrosis, people who have had transplants for pulmonary fibrosis, and also family members of those living with disease. So this is a great way to get involved, to contribute to the knowledge that we have of these diseases, and you know, participate. All right, Scott, any last thoughts there?
I just can't underscore the involvement in the community registry enough. We also have a large number of companies who are exploring drug treatments, and they are looking for participants. And we actually use the community registry to spread further awareness to those trials.
Absolutely. It's a great opportunity to be in the know. Our last question for you, Scott. You've answered 2 correctly. I think if you get this 3rd question correct, the rules say that I have to get you a home answering machine and leave a message on it or something like that. I'm not sure, but I understand you have a bilingual household. So your last question, which of the following is the French term for pulmonary fibrosis? Is it fibrosis pulmonaire? Is it B, lungenfibrose? Is it C, you're going to correct my pronunciation on these, fibrosis pulmonaire, or fibrosis pulmonary? Oh, I don't know. Maybe I said that wrong. But Scott, can you give me the correct pronunciation of the French version of this? Let's see. We'll give our audience, I think we're good here.
Well, I can tell you that my wife and my in-laws will be ashamed of me if I don't get this one right.
All right, let's see the answer to those, our poll responses here. There we go. All right. What do you think, Scott?
A lot of potential Francophone folks with us today. So I would say it is C, Fibrosis pulmonaire.
Pulmonary. I said that wrong, but you got it right. Thank you, Scott. You are 3 out of 3 correct today. And we really appreciate you being here, and thank you for joining us.
Thank you, Amy.
Of course, I'm going to bring our panel back on here and get to our lightning round. All right. In just a moment, panel, we will not play the listener limerick challenge because I really don't want to get in trouble with National Public Radio, but we will play a lightning round. Before we get started, I do want to let you know that we are going to have some question and answer for our panel who are able to stay with us for the last few minutes of this session. So if you want to go to the Q&A tab on your control panel and send us those questions, we will get to as many of them as we can with the time we have left during our session. So panel, all right, each of our players will have 60 seconds to answer as many questions as they can, as many as I can get to. Each correct answer is worth 2 points, but I don't think it matters because I'm actually not keeping score. So we'll start with Joyce. Are you ready to go here?
I'm ready.
All right, let's see. Here we go. Oh, it's 5 minutes. We got to go to a 1-minute timer. Here we go. Okay. Here we go. All right, your first question. A program of structured exercise for people with chronic lung disease is called?
Pulmonary rehab.
Excellent. Nintedanib and pirfenidone are both FDA-approved treatments for?
IPF.
Blank-based therapies for pulmonary fibrosis are in early development but are not recommended outside of clinical trials.
So I was going to say gene-based or cell-based therapies, but
Yeah, ding. Oh, I have a bell, actually. I haven't gotten it out, but ding, yay. Launched this week, the Pulmonary Fibrosis Foundation's Blank is a one-stop resource for newly diagnosed patients and their loved ones to learn about PF.
PF basics for the newly diagnosed patient.
Excellent. You are listening. That's so great. Blank is medical care focused on quality of life and relieving symptoms that can and should be delivered alongside disease-specific care and life-prolonging care.
Palliative care.
Excellent. Yes, I need a gong, I don't have one. Okay. Great job. Great job. Great job. All right. Next up, I think Sonia is next. Wait, yeah. Okay, Sonia, you're next. We're going to get going here, restarting the timer. Okay, here we go. A major surgical procedure, blank, is a life-saving treatment for end-stage pulmonary fibrosis that improves quality of life in eligible patients.
Would that be lung transplant?
Great job. I'm going to use my bell. Completed before new medications can be tested in humans, blank often uses mice or tissue samples to understand how a drug might work in people.
That sounds to me like preclinical testing or clinical trial, early phase clinical trials.
Perfect. That's perfect. Systemic sclerosis, rheumatoid arthritis, and inflammatory myositis are examples of blank that can cause interstitial lung disease.
Those would be autoimmune conditions.
Excellent. Preventive care, such as seasonal blanks, are recommended as part of comprehensive management of ILD.
Oh, that's really important. That's vaccination.
Excellent. Great job. All right, we are out of time on that one. You did great. I'm not sure how many we got to, but you got them all correct. All right, Ross, you're up. This is our last round here. All right, we're getting started. There we go. Next, famous for his many acting roles, including Don Corleone and The Godfather, blank passed away from IPF at the age of 80 in 2004.
Who is Marlon Brando?
Yes, if we were on Jeopardy, you would get full credit for that. The both in-person and virtual options for blank are offered by the PFF and can be found using a search tool on the website.
Patient support groups.
Excellent. Ding, I'll give you that one. The blank is comprised of more than 80 ILD centers with expertise in the care of patients with pulmonary fibrosis and ILD.
The PFF Care Network.
Excellent. Research studies that explore whether a medical therapy is safe and effective in humans are known as blank.
Clinical trials.
Very good. Known as HR 7829 or SB 3821, the Blank Act seeks to improve the payment method for and access to supplemental oxygen among Medicare beneficiaries.
I'm out of time.
You are. Answer. You get to answer while I'm longing.
I actually am glad that I'm out of time because of my name. The name is that's terrible. Sonia.
The SOAR Act. It's the SOAR Act.
For some reason, my brain was blanking for a second.
That was great. Thank you guys so much. You guys are all spectacular resources for this information. I am so grateful to all of you for being here today, and thank you for being willing to be just a little bit silly with us as we go through some of this kind of heavy information at times. I'm just so appreciative of all of you. We do have a few minutes left for those of you who can stay and take some of our audience questions. I know that I will share with the audience that our panelists here are physicians, and in addition to all of their accomplishments, they directly take care of patients, and some of them are seeing clinic patients today, and so may have to pop out, but I appreciate your time. So as many folks as we can, we'll try to get to some questions before we need to end our session today. All right, bye, Ross. Thank you so much. All right. So Sonia, do you have time for one?
Yes, I have time for probably just one.
All right. Can you talk about an association with pulmonary fibrosis? And I have a question here about pulmonary fibrosis and weight loss. We might also include frailty there and so on.
Yeah, that's a really good question. So one of the things that can occur when a person has pulmonary fibrosis is that because of the or interstitial lung disease, because of the added effort of breathing, some people find that they lose weight. Now, the other thing is that sometimes there can be side effects from medications that can cause people to lose weight. What we know is that there's probably kind of a best or close to best weight for most people. We sometimes talk about this idea of body mass index, which is sort of a measure of a person's weight compared to their height. So when we have a patient whose weight is above that, we try to encourage them to exercise and do things which will help them get their weight into a better, healthier range. But we also want to make sure that people who are losing a lot of weight, who drop below that weight, are actually really focusing on their nutrition in order to make sure that they're taking in enough calories to be able to maintain their weight in that ideal range. So it is a complicated thing, and we often work with other people like nutritionists and obviously primary care providers to help us with our patients finding that perfect balance of weight where it allows them to be as healthy as possible without losing too much muscle mass and then starting.
I think we may have, if I'm not the one that's frozen, I think Sonia may have frozen on us.
Amy, it appears Sonia
Yeah,
froze.
I think we have. I think we do have that. All of those are really important points. I would thank Sonia for giving those. I am going to move on to actually another question since we are so frozen there. Joyce, this is a great question for you actually about how many patients that have pulmonary fibrosis have familial disease, or how many do we estimate have familial disease? And maybe talk a little bit about that for us.
Yeah, I think the estimates are around a third of our patients with pulmonary fibrosis have a family history or some genetic, significant genetic contribution to their condition.
Excellent. Can you, well, let me go on to another question, actually. I am going to, since now you're my only panelist left, and I don't think it's fair for me to ask all the questions of you. We'll go around robin, and I will, I'll hit another one here. There was a question I just saw. Sorry, I'm scrolling through them. About pulmonary rehabilitation in pulmonary fibrosis. And Joyce, feel free to chime in here as well. But the question is it appropriate for everyone with pulmonary fibrosis? And I think in general, my approach is to offer that to just about everybody and then have a discussion for those who feel like it may not benefit them. Usually when somebody is sort of on the early side and in really, well preserved lung function and physically in quite good shape, who also already have an existing exercise routine that they're doing in and it's balanced, right? So aerobic exercise as well as some weight training and muscle conditioning. If that's already in place, then I may delay that referral to pulmonary rehab a bit. But really, that's more of a conversation. Many people out there don't have those established habits, and there are things that they can get from a pulmonary rehabilitation program to teach those habits, to create some accountability, to learn what they can do safely and know how to progress. The other benefits of pulmonary rehabilitation are that there are a lot of education built into pulmonary rehabilitation programs that are surrounding nutrition and, if needed, smoking cessation, oxygen education, disease-based education, not just the learning of how to do the exercises. So in general, I think it's a good practice to offer that and talk, about the benefits of it, because there may be some things that could be learned, and it is has a defined beginning, middle, and end. So getting the benefits out of it, when they're needed, I think is something we're looking for as many people as possible. And in general, I think it's really underutilized as a resource for folks. Joyce, this is actually a good question. I think, well, let me go with this one first. So we're running a little low on time, but this may be a little bit more broad appeal to it. Medications available to treat pulmonary fibrosis, do they differ based on specific diagnosis?
Yes, absolutely. They definitely depend on underlying diagnosis, which is why we as ILD physicians spend so much time trying to get to a definitive diagnosis, because depending on what underlying diagnosis you have, we might actually pull for immune suppression first, especially if you have an underlying autoimmune condition, for example, versus avoiding immune suppression in patients who have conditions like IPF. So I think diagnosis absolutely makes a difference in terms of treatment approach.
Excellent, thank you. Yeah. I'm going to try and get maybe 2 more questions in before we quit here. This is actually a really interesting one. How do we feel? Joyce, I'd like your opinion on this as well. I'll go ahead and say what I think. How do we feel about getting second opinions from doctors in different centers or different hospitals? Are most of them okay working collaboratively with others? And what's that approach? So I think all doctors are different. Let me say that. I would say that in general, I as a physician welcome other opinions particularly from other expert centers. I am fortunate to work in one of the Pulmonary Fibrosis Foundation's care centers in the Care Center Network. There are 81 care center sites across the country and 7 clinical associate sites that have demonstrated experience and expertise, access to the types of supportive care that are appropriate, that are adhering to standard of care for the diagnosis and management of interstitial lung disease. And so I think, patients and caregivers want to self-advocate for the best care that's out there. And if another opinion is felt to be something that they would want to look into. I certainly advocate being open with your primary pulmonologist about that. But I would also advocate strongly for looking at centers within the care center network, because I think those can, in general, deliver the quality of care, the level of experience that we would hope that that our patients in our community would receive. Joyce, what are your thoughts on that? It's a heavy question.
It is. And I too, I think it's always a discussion with your patient. Every doctor is different. I encourage patients, if they're interested in seeking second opinions, to do so. These diagnoses are not easy to make, right? And so making sure that you feel confident that the diagnosis that you have is makes the most sense for you, I think is really important. And, I think, of course, it depends on the physicians in terms of the ability to collaborate and things like that. But certainly in my practice, we're very open to having patients seek second opinions if needed.
Absolutely. Joyce, thank you so much